Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hello, I'm Tony Urbina, the Medical Director for CEI's HIV Primary Care and Prevention Center of Excellence. I am a provider and professor of medicine at the Icahn School of Medicine at Mount Sinai, and I've worked in HIV and LGBTQ health for over 20 years. Cultural humility in healthcare, especially for those involved in kink, requires going beyond basic competence. Clinicians must provide respectful care, acknowledging patients' diverse backgrounds and beliefs about kink as part of their identity. This necessitates self-reflection, ongoing learning, and awareness of the doctor-patient power dynamic. While BDSM and kink were previously categorized as mental disorders, recent progress acknowledges consensual practices as distinct from harmful paraphilias. However, some healthcare professionals still hold unfounded biases, highlighting the need for further education and combating the stigma surrounding healthy expressions of sexuality. In this episode, I speak with two experts about their work studying kink and HIV prevention within the kink community. Anna Randall is the co-founder and executive director of TASHRA, the Alternative Sexualities Health Research Alliance. Over the last 25 years, Dr. Randall has focused on healthcare disparities, healthcare experience, consent, and injuries in kink and BDSM interested individuals as kink becomes an emerging scientific area of research and clinical practice. Anna earned her MSW from Boston University. In San Francisco, she completed her master's in public health and a doctorate in human sexuality at the Institute for the Advanced Study of Human Sexuality. She co-leads the International Kink Health Study and the Prep for Kink study with her international multidisciplinary team. Richard Sprout received his PhD in developmental psychology from UC Berkeley in 1994. He is the author of Sexual Outsiders, Understanding BDSM Sexualities and Communities, and co-editor of a new book series, Diverse Sexualities, Gender, and Relationships. Richard is currently the research director of TASHRA and is working with Anna on the International Kink Health and Prep for Kink studies. Welcome, Anna and Richard. Thank you for joining me today. Let's start off. Why don't you tell me a little bit about your background and what got you into this work? And let's just start with Anna.
I started working in women's health about actually a little bit more than 30 years ago. And when I finished my doctorate in human sexuality, I was really interested in not just women's sexual health, but I was getting really very interested in how sexual behaviors really impacted people. And Richard and I started talking about 12 years ago about kink in particular. And we were we thought that research was starting to surge in this area. And we were predicting that there was going to be a real upswing in this area, and also in the need for more clinicians to be interested in kink. And so that's how we came together 12 years ago to start our organization, was out of this interest both of us had.
Very interesting. Richard?
Well, not being a sex therapist like Anna, I am a developmental psychologist and research psychologist. And it was about I made a switch from working primarily in child development issues to adult development, and in particular, the development of sexual identities. And back in 2005, I decided that an area that was really under-researched was people involved in kink, fetish, BDSM, sometimes called the leather community in certain circles. All of this was definitely ignored, except for a few pioneers who were attempting to address the health needs and just trying to understand this alternative sexuality. So by the time 2012 came around and Anna and I were talking about the need in particular for research on health and kink, it seemed very natural to create an organization, a community-based organization that would actually address this by doing research and then taking those research findings and translating them into clinical trainings for healthcare providers. And that's what we've been doing since 2012.
Wow. Very interesting. Thank you both for sharing that. So I'd love to start off the discussion. I know a lot of terms have already been presented, but just a quick history of kink and just a list of helpful terminologies that may inform our listeners. So you want to start with just what is kink and other terms that you kind of threw out there. So BDSM and et cetera.
I think I'll start just by saying that language always evolves, right?
Mm-hmm.
And particularly in subcultures, right? Where they're trying to find their place and trying to establish what they are, both for themselves, for the in-group, and then for the out-group. And how psychiatry over the years has identified these terms is very different than how the communities or the people involved in these identify them. So I'll let Richard kind of define some of the terms that we're going to be using.
So when we go and look at actually how healthcare or the scientific literature has addressed issues around alternative sexualities, one of the terms that was created was paraphilia or paraphilic disorders. And that was very definitely an outside perspective and primarily pathologizing. The idea that somehow in some way, if you were interested in things like bondage or playing with somebody having more power and authority in a sexual encounter than the other person, all of this would be somehow an expression of, some past trauma or some really bad parenting or something like that. And starting, I would say, perhaps a little bit in the 70s, definitely a little bit in the 80s, there started to be a kind of, well, what if we looked at these kinds of behaviors, not from a pathologizing point of view, but just what is it and what's going on? One of the primary things I think that was pretty revolutionary in terms of addressing this from a more healthcare position was recognizing that this was a community. A lot of the images and a lot of the case studies that were published, before the 70s and 80s around strange sexual interests really always portrayed the person as isolated, as very much an outlier, as not connected to any kind of community in any way. But in fact, the history of sexual communities that were built around these interests and around these fantasies and behaviors actually started in the United States, started really forming in a more formal way in the 1930s. And then definitely by the 50s and 60s, we had a lot of growth in terms of the subculture. And it really took off again in the 70s and 80s. So this recognition that there is a community that does all of the things that you would expect a culture to do around things like these alternative interests really was a nice, I won't say corrective, but definitely a counter to the image that really came out of the medical literature before the 70s and 80s. So when we're talking about these things, kink is a really huge umbrella. It covers so many different things, fetishes of all different types, interests in particular sensory experiences, looks, smells, the feel of things, right? The touch, all of these being sort of somehow in some way sexually exciting, even though they're not your prototypical or stereotypical thing that would arouse people. Lots of interest in things like power and how power is experienced as an erotic component to an encounter. There tends to be a lot of focus on sensory experience in terms of pain, although pain is a very complex perception and a very complex experience. And so the whole idea that people might experience pleasure and pain in a particular activity definitely gets really tested by people involved in BDSM. And BDSM is a compound acronym BD stands for bondage and discipline. DS stands for dominance and submission. And SM stands for sadism and masochism. So BDSM. And that was a term that was introduced by researchers and people in the professions to talk about these things without having to use the term paraphilia, just in an attempt to not be automatically pathologizing. But it's a term that got adopted by the community and often is used. Those are just some things. We could go on and on about all sorts of kinks under the umbrella.
Those are very helpful starting points for us. So I think, Richard, you kind of mentioned this whole thing, kind of the power dynamic. And I just kind of want to ask, so where does kind of consent fit in with kink? And just why do you think that kink is an unrecognized sexual minority?
And those are great questions. I think one of the things to think about is that many people don't know that one of the kind of hallmarks of BDSM and kink in these communities is this ethos of consent. The primary drive here is that this is adult consensual behavior that is highly negotiated. It is highly discussed. People have very particular kind of protocols for how they discuss these things. There are safe words that are involved, and the folks in BDSM and kink are the people that created this concept of safe words. When I used to lecture on this 10 years ago, I'd ask a group of college or graduate students who knew about safe words, and there'd be 3 or 4 people who raised their hands, and I knew those were the kinky people in the room. And now when I ask, everybody knows what safe words are. That doesn't necessarily mean that they know how to use them as effectively as people in the kinky universe do. But personal limits, this idea of personal limits and safe words is highly kind of conceptualized and institutionalized somewhat within the kink community. And I think that's what makes this very distinguished from things like abuse. That doesn't mean that abuse can't happen in these relationships. It can, they can coexist. But the actual BDSM activities that people do are highly driven by a consent-based subculture. As for, why this isn't a recognized sexual minority, it's a very interesting and complex question because as it's identified, as the SG division calls it, they talk about it as people who identify as lesbian, gay, bisexual, asexual, transgender, two-spirit, queer, and or intersex, individuals who with same-sex or gender attractions and behaviors, and those with a difference in sex development. So that's kind of how they decide it. And, we go back and forth in this field about, do we have to be an orientation in order to be accepted as a sexual and gender minority? And right now, we're not identified as a sexual or gender minority. Although I do think in order to do that, they want us to show that there are health disparities. And our research and other burgeoning research is showing that these folks do have health disparities. Much of this caused by minority stress, the impact of minority stress. It is stuff to think about and something that would be really beneficial for understanding, because it would also open up the possibility of research money and understanding these folks better when it comes to protecting their health and understanding what's also beneficial and possibly healing about some of these experiences.
Very interesting. And just speaking about research, I also know that you're involved in this PrEP for Kink study. And I know one of the things as clinicians, especially involved in sexual health, is just to really promote good sexual health, but talk about like biomedical prevention, like PrEP. So, Richard, did you want to talk a little bit about your PrEP for Kink study and how you think that fits into the kink community and just any kind of information that you have about this study?
So we were approached by someone at Gilead Sciences to say, hey, you guys do things with this particular community. Do you think that you could do a study in particular about HIV education and prevention with a focus on PrEP? And we were like, sure, we can, because of some of the health disparities we have seen. In particular, the gay male leather community or kink community had been really hard hit by HIV in the 80s. In fact, a study back, one of the very few studies about this issue was done back in 2011 and found that about 27% of gay leather men were HIV positive, which was a very incredibly high number for a particular population. And the idea that this was a very vulnerable population seemed very natural to us. However, there is nothing out there in terms of directly addressing and communicating with this population about things like HIV and PrEP. So we thought we would do a study that would look in particular at messages that were essentially sex positive and generic about PrEP and compare that to messages that were definitely couched in the kink community's language and imagery and ethos. So we're looking to see whether or not messages that are specific to a particular community actually are more effective in education around HIV prevention. I think you can assume that we expect it will be more effective, but we really do need to test it. And so we're in the middle of a study that would compare these different types of messaging and to really look more carefully at what it is that people know and understand. The focus of it is on segments of the kink community that are not gay male leather. Because again, that particular community has received a lot of attention, a lot of messaging, a lot of education, a lot of prevention. But the kink, again, the kink umbrella covers so many different types of people. The gender and sexual orientation diversity of the kink population is huge. And so there are lots of people who are not being reached around HIV education or prevention efforts. So we really want to take a look at the effectiveness, the impact of this kind of messaging on what people know and their attitudes about taking preventative measures to protect themselves from HIV.
Yeah, no, I think those findings are going to be really important. So as we kind of know, like the sexual health research really shows that patients want their healthcare providers to talk with them about their sexual health, and they want, those positive interactions. I know that now when I take a sexual history, I'm part of that CDC, the partners, practices, protection from STIs, past history of STIs. And maybe, Anna, I can direct that to you, but how do we start to introduce this topic about kinks with our patients in a way that's inclusive and also respectful? So how do we open the door to have these conversations? Is there any advice or tips that you would give to clinicians?
It's interesting, Tony, because what you were talking about they're very typical questions that health providers ask, right?
Yeah.
But they also come from a kind of disease model, and they also come from a non-pleasure perspective, right? So one of the things I think is also helpful in there to ask is something like, is there anything about your sexual interests and practices that you might have questions about? So I think part of that is also kind of opening it from a place of curiosity, which is to say to them, you might have practice, you might be doing things that you might have questions about, and you might, benefit from having a medical provider, ask those questions. And also many times health providers don't know the answers, but the biggest one is to say, I don't know, and let's find those out. I'd be happy to look it up. I think that's part of the conversation. One of the things that we have seen in the research is that people don't want you just to flag that you have an interest in this. They actually want to know that it's more than just that you've got a little pride flag up or that you have a little BDSM flag up, but they actually want to know that you're actually interested in it. And unfortunately, there's not enough medical information out there for folks. It's like somebody comes in and says they're doing urethral sounding. And I was just at a medical conference last week of the Women's Sexual Health Association. And one of the things people were saying is, oh my God, they're doing sounding. What are they using? And somebody said they're using sounding. I mean, they're using actual urethral sounds. And people were like, how do they know how to do them? And I'm like, they train each other how to do these things. But medical providers aren't aware that's what's going on. But if they know that's what's going on, then they can talk to their patients about, if you're doing this, let's talk about some ways that I know, or there's contraindications, given that somebody might have some health condition that could be, really contraindicated in some kind of play that they're interested in doing.
Some really excellent points that I think all of us can really incorporate. And Richard, any other thoughts about how you think we can destigmatize these types of issues that come up in the kink community, and what valuable advice we can give to clinicians for how to do this?
I think one of the first points I often make when trying to address this is you're already seeing these patients and clients. You already are. They're just not telling you. In our work, in our research, we have found that about 50% of people involved in kink do not tell their doctors, do not tell their therapists. They do not come out about it. And then those who do often are sometimes reacting to being shamed about their interest in practice by a healthcare provider in the past, and they don't want that to happen again. Sometimes some of them are coming out as a way to, because they have specific questions about their interests and their behaviors that they really would like to talk with a doctor about. And so sometimes if they have a particular like past injury or an experience where it raises questions about their health, they do want to. But most people really are afraid. They're afraid of how their doctor is going to respond. And while we can see in the research that sometimes they will have a bad reaction, a bad response, that's very shaming and difficult. We've heard things like a therapist saying, I can't see you until you stop doing this. Doctors who basically look completely blank and then change the topic to something else, just do not respond in any kind of positive way. When people encounter those things, they're afraid. And while those negative kind of responses do happen, they don't happen very often. It's the fear that they're going to happen that really keeps people silent and not disclosing what it is they're actually doing or what kinds of relationships they're actually in. So just trying to get across that these kinds of interests cover, people of all ages, people from all different walks of life, and you are seeing them even if you don't know, because they often are afraid of how you're going to react. And I think just being able to be sensitive to that gives motivation for asking the question that Anna suggested, like, is there anything about your sexual interests or behaviors that you might have questions about?
Yeah, no, that open-ended approach. Well, thank you both for joining me today. Very interesting conversation. I'm sure a lot of our listeners will be very interested in this topic, and hopefully we can spread the word. So how can people learn more about your work?
Well, you can contact us. Our website is TASHRA, TASHRA.org. And so people can find us through that. That's a good way to find us. Kink-Health.org is another one of our sites that leads to one of our research projects that is actually closing down at the end of the month. We're stopping recruiting then. And Kink and the Prep for Kink study is also at prepforkink.org. And so people can find it there. But tashra.org is a great place to find us. And Richard and I can be reached through that as well.
Great. Excellent. Well, thank you for listening to our conversation today. And to learn more, please check out our podcast notes or go to ceitraining.org.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.